Ugandans desire to have access to affordable quality healthcare and education services. We all know that if we got education and health right, we would save money, we would save lives, we would have development at community level. The slow progress is mainly attributed to the current health service delivery system, which is facility-based, that as community, you become relevant only when you are sick. If you are not sick, then the health center the health system has no plans for you, has no time for you. During the vision period, there will be a paradigm shift from facility-based to household-based health delivery system. This shift will be anchored on preventive over curative health services delivery approaches. And this speaks to how much we are thinking about village health teams, health unit management committees for managing health centers, but also community empowerment to demand and hold service providers accountable. The National Development Plan Objective 2 is to ensure universal access to quality, universal minimum health care package with emphasis on vulnerable groups. It also observes that high mortality is not due to lack of appropriate policies in Uganda, but rather inadequate policy implementation. Over 75% of the disease burden can be prevented through health promotion and prevention. Preventive interventions through cost-effectiveness have not been given adequate attention. And even if we think basically on malaria, which has been with us for so many years, taking 320 people per day, malaria is 100% preventable. And we have had innovations including the mosquito nets, the residual spraying, but we have not seen malaria going away. So what is it that we are not doing that we should be doing? The second national health policy emphasizes primary health care, and that it remains the major strategy for the delivery of health service in Uganda because of the 75% preventable burden of the disease. Greater attention and support should be given to health promotion, education, environment, health, enforcement, and preventive interventions are defined. But this cannot happen without the leadership and support at community level. It's not enough for us to make the pronouncements. We need to support the community to realize this. So we would like to conclude from the above that Uganda's policy is unanimously focused on achieving a healthy population through primary health care. There are no contradictions across all policies. We feel like we are speaking to the converted. It therefore makes technical and political sense to say that the current health challenges are not rooted in policy, but we agree that this is about. As Minister of Health observes, the problem has been and remains implementation. According to the National Development Plan, the per capita cost of providing the current minimum health care package was estimated at $41. It has since remained chronically underfunded at 10. You can imagine the difference. This is also against the increasing burden disease, but also the poverty. So we think that this heavily downward trend is very dangerous, and we think that if we do not focus on this in the future, if you look at the non-wage 15 billion, 15.8, almost 16. What we are asking for is 56 billion. Just to make them functional, to make Health Center 2 and Health Center 3 and 4 where we have a theater, just to make them functional, nothing fancy. This is a big difference. The reason is because we have been going down over the years, and it makes it very difficult for us now to kind of rise up. So we want to reiterate our request this morning, Mr. Chairman, that we include per capita on primary health care to meet the priorities and projections. One, that two, this financial year work towards meeting the estimates required to effectively implement primary health care from 15 billion to 56 billion. The gap is very big. We also want to conclude by requesting that we strengthen citizens' responsibility to prevent and promote health for education, increase accountability and participation in the course of implementation, so that there is value for money even within the scarce resources. We want to thank you very much.
We've heard that the Ministry of Health is getting money from Global Fund to fund to fund the village health teams also. And I know somebody in this room can confirm to that. So specifically, our submission this morning is to look at the functionality of the health facilities, you know, to look at that, because we hear at least the VHTs are getting support from somewhere that is coming in, but the functionality of the health centers specifically remains very critical, and I think that is why we are here this morning, and that's why Madame Robina's presentation remains very important. So if you could just pay attention to that, we would really appreciate it.
Of repair and maintenance is still critical when we talk about primary health care, especially at the district levels. Many districts are struggling with bills. You remember the incident in Murago. It is not only in Murago, it is happening all over the districts. But if you don't invest in primary health care in that way, then it means the health facilities that are suffering with water bills of around 6 million, 3 million at health center 3s, they will not be in position to fulfill these obligations. And for us, we feel if the local governments cannot afford to pay these bills, government should centralize.
We are also wondering whether these public places like the hospitals and health centers can be looked into when it comes to the prepaid system that is currently going around the country. Are we ready to take it on in our public facilities like the hospitals, where it's a matter of life and death? Maybe these are things that Parliament needs to look into. But also the issue of Mulago needs to be taken seriously, where they found like 200 families were illegally connected to the hospital. Are we putting interest to see that there is an end to this, so that the people don't suffer at the expense of death?
That we really have good policies in place, like we have seen the Vision 2040, the aspiration, we have the National Development Plan, the National Health Policy, the manifesto, and different commitments that government have been making on specifically improving maternal health, primary health care. But when it comes to appropriation, when it comes to budgeting, then the story is different. When you look, for example, the budget that we received last year, which was around 800 billion, you find 30% of that money goes to human resource. The 30% goes to capital development. 20% go to medicines. And that remaining one, which is almost less than 10, it is the one that goes to service delivery, which includes primary health care. And that's why you find that even like a health center 3, they are getting, for example, non-wage, they get 300 per quarter, meaning that that is 100 per month to run a health center through which receives around 500 members. I think that is really embarrassing to all of us that we are not giving the attention that we should be giving to primary health care.
Because we are starting to scrutinize the budget framework paper as part of the budgeting process, and let's continue working together to see what we can push, because our goals, our objectives are basically the same. So basically we agree with, at least on my side, agree with the issues you are raising, and we must rethink the whole implementation of the health policy up to grassroots. Because there are many things, like someone will say, which we can improve even without necessarily increasing the budget. Because we have health assistants, we have health inspectors, but they are not working. We have parish chiefs, we have health educators, we have elected leaders, LOCs, but somehow they are not functioning in as far as improving health of the community is concerned. And with the decentralization, there seems to be a disconnect between between the Ministry of Health and the decentralized health services, and even from the district, the community. And I think as a committee, we need to interrogate all this and see what we can improve.
When they renovated the Bull Health Center, all the materials that were there, the scrap was brought to that place, but now nothing is there. It is just there, clean. Yet mothers produce every day. Just in Bokoto, it's in Kampala, Nakawa division, for the last 15 years. The little amount, yeah, it has been there. It's there. It's under KCCA. We just went there recently. We entered so that at least we can let the people in the area know that we can use that facility. But when we went there for this mass immunization that was there last weekend, people were there. The health workers were not there. Nothing was brought at the site. That's what we're talking about, the VHTs. They are there to work, but nothing is brought at the grassroots level. So the little amount of money that is also budgeted for, no one monitors. Yet we need monitoring and supervision of the little funds that we also have. And more mothers will be infected. For example, in the communities, a mother will just go to the nearby health center, which doesn't have all the facilities, yet we have a facility that would have been facilitated. Yet we are fighting, we are trying to eradicate mother too.
Because changing from curative, now we are going curative because everybody is asking for medicine that's so on, and this government is making some political capital out of it by increasing medicines in hospitals, which is okay because people are sick. But to depart from that is a process that needs to be informed by information based on research, findings on how community health, health at a community level can be managed effectively, and the amount of funding that would be needed. Not to load the VHTs per se, because they are not professionals, but to see what they can do. Secondly, on how civil society can help government in working with the elected leaders at the grassroots level. For instance, LC1, they have got, I think, a person in charge of health, who may not be your VHT. By virtue of their appointment or election, they are the people concerned with it.
So the best thing to do is first make sure that as much as possible, prevent as many people as you can from falling sick. Then you can have few cases to deal with in terms of treatment. That makes it manageable. You and me know in Kampala here that you will not, the first choice will not be to go to Mulago when you have a problem. Why? And we are making the highest investment in the treatment, which must be in Mulago and in other public health facilities. But why are we not going there? Why? So practically, it is impossible for Uganda to think that you are going to invest in the curative care and deal with health and you solve the problems. The practical way is to prevent disease, and of course you will not rule out falling sick, but you have a lesser pressure and burden exerted on the system to care for. And you see,
health is made at home and only repaired in hospitals. So if health is made at home, the case we are making today of PHC goes a long way to support that. If we manage to secure more funding for PHC, I am convinced that in one way or the other we will be helping to end